So just to review that, on an EKG, the P wave represents atrial depolarization, right? And we went through what the normal P wave looks like, how big it is, and all that kind of stuff. The PR interval, what does your sheet say? Breaks it down a little more than what you learned in school. We learned that the PR interval is just the time between atrial depolarization and it getting through the AV node, right? But look at that piece of paper. It breaks it down a little further, right? So it talks about the impulses arrives at the AV, passes through the bundle of His, and then it causes the ventricular depolarization. What's the QRS complex represent? Ventricular depolarization. And what's happening at the same time the ventricles are depolarizing? Atrium is repolarizing, right? So once it goes through the AV, it gets to the bundle of His, the right and left bundle branch blocks, or the right and left bundle branches, and then the Purkinje fibers, and all of that. The time it takes to get through all of those electrical conduits is what causes the QRS complex. Now, I believe that we've been taught wrong. The vast majority of people do not have Q waves. You usually have RS waves. And we'll talk about Q waves here in a little while. So the T wave represents repolarization. And this says of the atrias and ventricles. Not sure where they come up with that. The T wave is similar to the P wave in that the first half of it is called the absolute refractory period, which means if an external stimulus was to fire on the front of the T wave, nothing will happen. The back half of it is called the relative refractory period, which means that if an external stimulus was to fire on the back half of it, so the T wave is supposed to be represents repolarization, and now I make it depolarize at the same time, what's going to happen to my patient? VFib, absolutely. VFib is trying to repolarize and we're making it depolarize. How could that happen? If a PVC was to fire on the back half of the T wave, that would cause that to happen. That's called R on T phenomenon. The R wave of a PVC falling on the relative refractory period of a T wave cause you go into VFib. Thus the old adage, how many PVCs does it take to kill you? One R on T. All right. The ST segment represents a period of inactivity between depolarization and repolarization. The ST segment is the thing that we're going to be evaluating on our 12 lead to look for what? Elevation or depression, correct? And what is the beginning of the ST segment called? J point. All right. All right, so we typically have multi-parameter monitors, right? What do our monitors do? They do limb leads, 12 leads, non-invasive blood pressure, pulse ox, CO, capnography. They do all kinds of stuff, right? I don't know of anybody that just carries a simple monitor that just monitors in 12 leads. You know, everybody's got these multi-parameter ones, so that's good. All right. So, assessment versus monitoring. How do we know we need to monitor somebody? Exactly. The thing that burns me up is when I either teach paramedic school or I do a national registry test and people have verbal diarrhea. O2 IV monitor, O2 IV monitor, O2 IV monitor. It's a freaking broken leg. You don't need a monitor. What did I say in the beginning? A monitor tells you 3 things. Rate, rhythm. Do you need to shock it or not? I can tell rate and rhythm off of a pulse check. Right? Maybe I need the monitor to tell me if I need to shock them or not. If it's really fast or it's not there, I'll buy that. But otherwise, no. Monitoring is continuous observation of the patient's condition. We just know that standard of care is anybody that's sick, we monitor their forelead. But if you really think it through, why are we doing that?
Because they said so.
Huh?
Because they said so.
Yeah, but if you think about the rationale for monitoring somebody, what's the rationale? If you're not treating them for a cardiac or pulmonary issue, what information are you really gaining from forelead monitoring?
I think, like he said, it's what you were taught. It's no different than you get pissed when the guys put an EKG on somebody that is obviously dead. And we really need to confirm that.
It's habit.
Right.
Yep. All right, so remember that limb leads go on the limbs, right? And it doesn't matter where, you can go anywhere from the wrist to the shoulder, from the ankle to the hip, doesn't matter, long as they're on the limbs. Precordial leads are different. They have very specific anatomical positions that you must use. So where does V1 go? What was it? Fourth intercostal, right sternal border. V2. Fourth intercostal, left sternal border. V4, midclavicular fifth. V3 goes between those. Anterior axillary for V5 and mid axillary for V6. All of those are on the fifth intercostal space. Very, very important that those get put on the correct place. Another bad habit that we have is not doing good skin prep. It says the electrode is sensing the current directly through the skin. Is it going to sense through dead skin very well? No. We just need to be in the habit of taking a 4x4 or an alcohol prep and rubbing really hard before we put our stickers on. Then, it doesn't matter. As long as you clean it off. Doesn't matter. The only thing about using alcohol is you got to let it dry. So it's better to use a 4x4 or the abrader pad on the back of your electrode just to rub the skin off.
We have sandpaper.
Well, yeah.
It's like sandpaper.
No, it is. It's in a tape roll.
Yeah, it's on paper. It's
Yeah.
like sandpaper.
And you can buy electrodes with that on the back.
I know you can.
Yeah. It's abrader pads
Yeah.
is all it is.
That's kind of
Yeah,
rough.
220 grit sandpaper.
Yep, that's what it is.
Yeah, it's made by 3M. And it comes on a roll just like, tape that you make Christmas presents out
It
of.
makes a big difference.
Sure it does.
That was just funny.
Yep.
It does seem like a Des Moines fire
It is,
thing.
it is sandpaper.
And here
Switch
is,
the hardware store.
well, I mean, think about when you get a stress test. They rub you raw.
Yeah.
That's why. Does their stuff ever come off? Do they typically have bad recordings?
No, they do it while you're running on a treadmill.
Exactly.
Yep.
While you're sweating.
While you're sweating.
Absolutely. This here, it burns me up that people just don't cut it to start with. We try it 3 or 4 times, it don't work, go get the razor. No, cut it now. Clip it now. We use the clipper, not a shaver, right? Why do we not use disposable razors? Little micro nicks. So then when we give them their heparin and their TPA and whatever else we give them, then they ooze out of all those micro nicks. So we use that 3M clipper with a disposable head. All right. So 6 limb leads provide a view of the heart on the vertical plane. The precordial leads are on the horizontal plane. We already talked about where all of these go. So I'm going to skip through that. All right, so anterior, V3 and V4, there is no reciprocals. The reciprocals would be V7 and 8 on the back, if you went around to the back. Inferior, 2, 3, and F. Reciprocals are 1 and AVL. Your lateral, 1 AVL 5 and 6. Your reciprocals are your inferior leads. Septum, V1 and 2. Again, the reciprocal would be on the back of the heart. There is no leads on the front or on the back unless you go around there and look. And then V1 and 2 would be your reciprocals. So I have this patient that's presenting like an acute coronary syndrome. I do not have any ST elevation anywhere, but I have significant ST depression in V2 and 3. That's my clue. I'm going to go around to the back and look. So I'm going to do a V7, 8, and 9. Okay? Does everybody remember how to do that? You move 4, 5, and 6. You just take them and you move them in the same intercostal space. One goes right beside your spine, one goes at the tip of your scapula, and the other one goes at your posterior axillary line. So there's 3 right there. That looks at the back of the heart. Okay, that's an 18 lead EKG. 15 lead is your normal 12 lead, and then your 3 right-sided. 18 is 3 more in the back. So anytime you have somebody that looks, acts, and smells like a STEMI, has some depression in the anterior leads, you need to go on the back and look. Because what did we say? 90% of people are right dominant. That makes sense? Huge. All right. So, this is kind of a no-brainer, but you need to check your leads to make sure that they stay on. So when we get our V-fib alarm, we don't immediately shock them, we check them out first. Right? All right. Just like a set of vital signs, you need at least 2 12 leads. Your initial 12 lead, and then right when you're pulling in the ER. Another good opportunity. I would tell you that you probably should do it every time there's a significant change. So I get this guy with 8/10 chest pain. I give him his aspirin, I give him a nitro, 5 minutes, I check him, he's at a 5 now. Push the button. 5 more minutes, he's at a 3. Push the button. I've had as many as 9 or 10 12 leads between the scene and the hospital before. Right? The cool thing about our LifePak 15s is once you turn them on and do the first 12 lead, they automatically look at it, the ST segment, every 30 seconds. If at 2.5 minutes there's been a significant change in that ST segment, it spits out another 12 lead for you. So that's called a what? Clue that something's changed. Right? Why are we doing that? If you had something like Prinzmetal's angina, so Prinzmetal's angina is what? Coronary vasospasms, right? What does nitro do? It's a smooth muscle relaxer, correct? So what if I had 4 millimeter of elevation in 2, 3, and F, and it's caused by Prinzmetal's angina, and I give them nitro, and now my 12 lead's normal when I get to the ER. What's the ER going to do? Blow you off. Right? They're going to look at your 12 lead and go, dump paramedic, there's nothing here. But if I had the first one, then I had the second one, look, I made the patient better. Why? Because that's my job, to make them better. Right? Kind of similar to, I don't hear any wheezing. Yeah, no shit, I gave him 4 albuterols before I got here. Really? Sure you don't hear any wheezing. All right. So, all this stuff, obviously we would like to have them in a supine position when we do our 12 lead, but we know that if they're having chest pain and shortness of breath, they're probably not going to tolerate that. So you get them in a position of comfort, and then try to make them as still as possible. Things that interfere with it, if they're cold, if they're moving their hands, tapping their feet, you know, if they're gripping the rails of the cot, whatever, you know, that's gonna mess up your 12 lead. Talks about getting calibration. We don't have to worry about that. The machines do that for you. If you look at your EKG, there's a big square box in the beginning and it goes up 10 little boxes. That's your one-time calibration. It's doing it on its own. All right. So it talks about P waves. We already talked about it. P wave is usually monophasic and positive in 1, 2 AVL and AVF. P wave is often biphasic in lead 3 and is negative in AVR. What's biphasic mean? Bi means 2. So remember your P wave sheet. Look at V1 on a normal P wave. It goes up and then it goes down. That's biphasic. It goes 2 ways. Just like a biphasic defibrillator. Goes from positive to negative, gets the heart in the middle, and then goes the other way. So we discharge more cardiac muscle with less energy because it's going 2 ways instead of 1 way. Does that make sense? All right, so V1, again, typically your P wave is biphasic. V2 and V4 are variable. So it says septal depolarization is not always seen on EKG. When it is, there will be a small Q wave in 1 AVL, V5, and V6. T waves will usually be recorded in a positive deflection and those same leads that record a positive R wave. So that's correct, that if our QRS goes up, our T wave should go up. Does that make sense? But if our QRS goes up and our T wave goes down, what could that indicate? Hypokalemia or ischemia, either one. All right. So just remember that a 12 lead specifically looks at the left ventricle. If I want to know anything about the right ventricle or the back of the ventricle, I have to go around there and look at it. It's just like pulling up on the A side of a house. You want to know what's going on in the CD corner, you have to go around there and look at it. That's why you do a 360. It's the same thing. Okay? All right. So this is what? Normal 12 lead, right? See anything in there weird? Everything looks good. All right, so we need to look at every 12 lead the same way. That way we don't miss anything. So I got you some 12 leads coming around.
No, it's 3M product. It comes on like a tape roll. Like it's not
For 3M, it's 3M.
Yeah, you can get it in Boundtree. All right, so looking at 12 leads the same way every time will ensure that you don't miss something. Okay? So the first thing you do is at the very top, you look at the rate. Should be within normal limits, right? Then you look at the PR interval. It should be less than 200 milliseconds. Then you look at the QRS duration. QRS duration should be less than 120 milliseconds. Then we're going to add something else for you to look at, and that's the QT, QTC. QT is the QT interval, the QTC is the QT interval corrected. QT interval corrected. So it takes into account other factors of the electricity. What's a normal QT or QTC? It's less than 450 milliseconds. Why is that important? Two things. The slower it gets, the longer the QT gets. There are certain meds, specifically like procainamide and antidepressants, that prolong the QT interval. A prolonged QT interval sets you up for torsades. So that's why like a tricyclic antidepressant prolongs your QT interval. Big side effect is it either widens your QRS or it causes torsades. Now, young kids that just drop dead, like playing basketball, typically what they find out is that they had long QT syndrome. And then they went into VTAC, torsades or something, couldn't be resuscitated. All right. Then we're going to go down V123, AVR, AVL, AVF, V123, V456. Okay, lead 123, AVR, AVL, AVF, V123, V456. We're going to look at the J point. We're going to see if it's a box, taller or not. If it is, we're going to put a check mark by it. We're going to go through all the leads. AVR should be negative. The whole thing should be upside down because it does not have a partner. And then we'll go back and anything that's got a check mark by it, we see if it goes together. So, what is significant? It has to be in two or more anatomically contiguous leads. So what does that mean? It means that it looks at the same or adjacent piece of heart muscle. So if I said I'm going to give you a free round trip ticket to anywhere in the contiguous United States, can you go to Hawaii? Can you go to Alaska? No, because they're not connected, right? So how do you know if something's anatomically contiguous? One, it has the same name. So like 2, 3, and F are inferior leads. 1 and AVL, V5 and V6 are lateral leads. V1 and V2 are septal leads. V3 and V4 are anterior leads. What page is that, Rebecca?
468.
If you look on 468, bottom left corner, there's a little color overlay. These are the anatomically contiguous leads. They made them color.
I think I have that one made while back.
The overhead, yep. So if they have the same name, they're anatomically contiguous. And if they're numerically sequential V leads, they're anatomically contiguous. So even though V1 and V2 are septal, V3 and V4 are anterior, if I had V2 and V3, that is significant because they are numerically sequential. Make sense? All right. We went through all of that stuff. Now, what about this wide or narrow QRS? Why do we care? Bundle branch blocks, what else? Ventricular beats, paced beats, all of those things, left ventricular hypertrophy, all those things potentially do what? Screw up our ability to see the ST segment, right? All right. We're going to watch another little video that's going to explain axis determination a whole lot better than I can. I have 2 handouts for you. One has 2 clocks on it. So One looks like this. And then the other one is another colored one that looks like this.
Greetings, everyone. In this video, we'll explore how to determine the overall QRS axis on the 12 lead EKG. In order to do that, one method of doing that is called the quadrant method, where we'll establish a 4-quadrant system by using 2 specific leads. Those will be leads 1 and leads AVF. And the reason we've chosen those 2 leads is because lead 1 is the only perfectly horizontal lead, and that's because it's created between the right arm and the left arm, where the right arm is negative, the left arm is positive, and normally it's created just between these 2. So that's a perfectly horizontal lead of lead 1. Next, we'll look at AVF. AVF's a little bit more complicated. Remember, AVF is created by Einthoven's triangle, where we take the right arm and we combine it with the left arm to create a new lead, which is right in the middle of those 2, finds the midpoint. And then the other pole of that is the left leg. And this creates a new lead, which is perfectly vertical, and that is lead AVF. And of course, all of the augmented voltage leads are positive in nature, and the other end is Wilson Central Terminal, and that has a 0 value. All right, so when you take lead 1 and you take lead AVF, you essentially create a quadrant system where you can now label these quadrants. And you can also define these quadrants by giving them some degrees or some numbers. So this is 0 degrees, this is 90 degrees, this of course 180 degrees, and this one is negative 90 degrees. So the 2 leads we're going to use, leads 1 and AVF, we're going to use those exclusively. There are certainly other methods out there, but these are the easiest ways of determining the overall axis. All right, so when we're talking about axis deviation, specifically in this video, we're talking about the frontal axis. This will be in the frontal plane. And we're essentially looking to see if we depolarize ventricular tissue, in which direction is that ventricular tissue depolarizing in? And we can accomplish that by looking and assigning a specific angle to that. This is a vector in essence, so there's a direction and a length of that vector. And we'll be able to determine that by looking at leads 1 and AVF. And again, you'll notice that this is lead 1 here, perfectly horizontal, and this is lead AVF. And then we'll have our little quadrants in these different areas here. So let's take a look at a little bit more. This is just a graphic representation of how the overall QRS complex will appear on the 12 lead EKG, depending on which direction it's traveling in. So if you take this as Wilson Central Terminal, take this as the AV node, the absolute center of the heart, if the ventricles depolarize from the view of lead AVF, so remember lead AVF is our perfectly vertical lead where it's positive down at the left leg. If we have depolarization of ventricular tissue in this direction, like so, you'll see that the QRS is not only upright, but it's going to be the tallest of all of the other QRSs. And the reason for that is because the depolarization vector is heading directly in the direction of that positive lead of AVF. So if the depolarization happens in this fashion or in this fashion, we'll also get a positive QRS because in fact, all of this is positive territory. No matter where you're heading here, this is all positive territory because it's to the bottom of this separator, which is the big red line here, separates positive and negative. So negative is up here and positive is down below. So anytime depolarization heads in the direction of positive, you're going to get a positive deflection on the EKG. Now, what will change is the amplitude or the vertical displacement of that QRS complex. In other words, as we start moving away from lead AVF, but still in a positive manner, the amplitude of that QRS complex tends to become smaller than it does if you're heading immediately in the direction of that lead. All right, so now conversely, if we have depolarization moving away from lead AVF, moving away from the positive lead, we get a negative deflection, and the same rules hold true. If you're moving exactly opposite of the direction of AVF, you'll get the deepest QRS deflection, and it will be negatively oriented, of course, because you're heading away from positive. And then no matter where you end up here, it doesn't matter where your direction is, as long as you're traveling away from or upwards from this red line, you're in the territory of negative, and you'll get a negative QRS. The only thing that will change then is the overall depth of that QRS complex. So now let's take a look at lead 1. So this is the perfectly horizontal lead. You'll see it's negative over here, it's positive at the left arm. And so if we separate this right down the middle, which is what that red line's doing, now we can start taking a look at, again, this is our central reference point here. This is Wilson Central Terminal, or the AV node. And when the QRS, or when the ventricles depolarize immediately in the direction of the left arm, you're going to get a nice upright QRS complex. And the reason for that is it's heading towards positive, in fact, immediately in the direction of that left arm electrode, and you're going to get a nice tall QRS complex. Again, this is the territory of positive, and therefore any time there's depolarization of the ventricles in the direction to the right of the screen here, you're going to get a positive deflection on your EKG, and that QRS complex therefore will be upright. Now, if the opposite happens, and we get depolarization in the direction of the right arm, meaning away from the positive pole of the left arm, then we're going to get our tallest, or I should say our deepest QRS deflection. And all of those other rules still apply. So this is all territory of the negative lead of the right arm, and as a result, no matter which direction we travel in here, in these quadrants area, or anything towards the left as you're looking at the screen, patient's right, you're going to get a negatively deflected QRS complex. All right, so let's take a look at these in summation. So if we have a positive lead 1, that means that the depolarization must be traveling in the direction of the right arm. If we have a positive lead AVF, that must mean that we have a deflection that's traveling towards the feet. And as a result, if we were to draw this quadrant, in order for us to have a depolarization that's traveling in this direction
This
and a
goes with what he's
depolarization
talking
that's
about.
happening in this direction, the only spot where these two things overlap is in this quadrant here, and this is the quadrant between 0 and 90 degrees, and this is known as the normal axis. Now, I'm kind of shortchanging you because, in fact, normal axis kind of goes from about negative 30 degrees to about 120 degrees. So it's a little bit broader than what we're displaying. But it's important to understand that this is an easy way, and this is a simple way of looking at the EKG very, very quickly and determining a rough ballpark. Are you normal, or is there a big problem? All right, so let's take a look at these next guys here. So we're going to do the same thing. We'll draw ourselves a little quadrant here. Let's take a look at the next one. So here's our intersection of leads 1 and AVF. And in this case, we have a positive lead 1, which must mean that we're traveling in this direction somewhere. And here in this case, we have a negative lead AVF, which must mean that we're traveling in this direction also. Where they overlap is in this quadrant here, and this change is called left axis deviation, and this is somewhere between 0 and negative 90 degrees. This is called left axis deviation. All right, let's take a look at the two remaining guys here. We'll reestablish our grid. There's our grid here. And in this case, we have a negative lead 1. In order for us to have a negative lead 1, we must be traveling somewhere in this direction. And in addition to that, the other piece is that we have a positive AVF, which means we must be traveling in this direction. Our overlap is in this quadrant, and this quadrant signifies 90 degrees to 180 degrees. This is known as right axis deviation. All right, and last but not least, the last quadrant we haven't touched yet. Let's take a quick peek. In order for us to have a negatively oriented lead 1, we must be traveling in this direction. And in order for us to have a negative lead AVF, we must be traveling in this direction, and our overlap is in this quadrant. This quadrant is between 180 degrees and 270 degrees, and this is known as extreme right axis deviation, also referred to as no man's land.
That's typically where you see
All right, so this is
VTAC.
just a simple way. This you have to kind of commit to memory.
So both of
And
them down.
if you
Almost
forget
always
this, then
VTAC.
hopefully you'll be able to kind of backtrack using the quadrant system. Remember, lead 1 is positive over here, lead AVF is positive over here, and this should allow you to determine then what quadrant the final vector is traveling in. All right, so let's take a look at a few examples here. So this is just kind of a half sheet of a 12 lead EKG. I've cut off the precordial leads, which often happen to the right here. V1 through V6 are not on this drawing. The only thing we've left here are the important leads for this exercise, and that is lead 1 and lead AVF. So if we want to determine what the axis is here, we're going to quickly take a look at the orientation of lead 1 and decide, is it upright or is it negatively oriented? So take a QRS complex. I think we'll all agree it is upright in this case.
What is it?
We're going to do the same thing for lead AVF. There's your QRS complex.
Normal?
It is also upright. In order for both of these to be upright, the only place this can be traveling is between 0 and 90 degrees. This is normal axis. Now, here's a little bit of a cheat for you. If you look on any 12-lead EKG, one of the bottom indicators here is going to be the P wave, the QRS, and the T wave axes. So this also translates to P, QRS, and T. This number in the middle is the QRS axis, and in fact, the EKG device has calculated a very specific 68 degrees. It tells us about normal axis. We got close. We said somewhere between 0 and 90, and that gives us exactly the same information. All right, so the cheat here, the quick cheat, is that you can always do the 12-lead EKG and take a quick peek at the number that's here. The EKG machine does do a pretty good job of that. The computer interpretation isn't so reliable, but these are usually pretty reliable. We'll talk more about that in a different video. So let's take a look at another example here. Again, our money leads here, lead 1 and AVF. Take a look at lead 1.
Which one's
Look at the
positive?
QRS complex. It's predominantly upright.
What hand?
Now we move to lead AVF. QRS complex is inverted. If you forget what to do here, you can always draw yourself a little grid. Remember that lead 1 is positive at the left arm. Lead AVF is positive at the left leg. And let's take a look here. In order for lead 1 to be upright, we've got to be moving in this direction. In order for AVF to be negative, we have to be moving in this direction. This is our quadrant that we're operating in. This is the left axis deviation quadrant. So in fact, when we have left axis deviation, we're indicating that the patient's electrical vector is occurring somewhere between 0 and negative 90 degrees. And lo and behold, if you look at this middle number here, it is negative 33 degrees. We're right on track with our quadrant system, pretty simple. Let's take a look at another example. In this example, we'll go to lead 1, which is here.
Which one?
We'll go to lead AVF down here, and let's take a quick peek. So
Not that hard.
lead 1 is negatively oriented. Lead AVF is positively
You'll
oriented.
get to it.
In order for us to end up there, we have to have a negative lead 1 traveling in this direction, and upright AVF must be traveling in this direction. This is our quadrant. This is the quadrant for right axis deviation. All right, we're almost done. We're almost done. We've got one more example. All right, so let's take a look at this guy. This is our lead 1 here. This is our lead AVF here. And if you take this ginormous wide QRS complex here, and also a ginormous wide QRS complex here, negatively oriented, negatively oriented. Remember, in order to be negatively oriented in lead 1 and AVF, we've got to be traveling in these directions. This is our overlap quadrant, and this quadrant is known as extreme right axis deviation. We also said extreme right axis deviation provided a number of somewhere between 180 and 270 degrees. And in fact, if we look here, lo and behold, we end up with 229. That's pretty darn good for a quick peek. All right, so this is our last example. Let's take a look at a few more things here. This is the cheat I was mentioning earlier. On every 12-lead EKG, take a look at that P, QRS, and T axis line, and that middle number for you is going to provide you with somewhat of a specific number for the overall QRS axis. I remember this is only for the ventricles that we're looking at with that middle number. All right, so let's take a look at what we do with this information. All right, well, if we have left axis deviation, important for us to think about two very common things associated with left axis deviation. The first is left ventricular hypertrophy can cause left axis deviation, and I'll tell you why that is in just a second. And the other one is left bundle branch block. So the two most common causes of left axis deviation are left ventricular hypertrophy and left bundle branch block. All right, so let's take another look here at what the other guys are. So this is right axis deviation. Most commonly, right axis deviation associated with right ventricular hypertrophy. You'll see there's some commonality here, right? As we start moving same direction. So left ventricular hypertrophy moves the vector towards the left. Right ventricular hypertrophy, more muscle mass on the right ventricle, shifts that vector over to the right axis. The other right axis deviation change of importance here is sodium channel blocker toxicity. This is an important one not to miss, and we'll talk more about that in a separate video. And then last but not least, extreme right axis deviation. This is generally very rare, and you're going to see it almost exclusively in VTAC. So VTAC is going to produce extreme right axis deviation. And I want to spend just a second on that just to explain why that's the case. So this is my best attempt at a heart. Right, here are the atria and the ventricles. Here is our normal depolarization. Normally things depolarize in this direction. But when we have ventricular tachycardia, so this is our SA, AV ventricles, and we normally depolarize in that order. When we have a ventricular rhythm or ventricular tachycardia, we have a focus of stimulation that's originating in the ventricular tissue. And when that ventricular tissue depolarizes, it depolarizes in this direction. When it depolarizes in this direction, think about those two leads that we were looking at just a few moments ago to determine axis. We were looking at lead 1, and we were looking at lead AVF. So now let's plot this arrow right here, and you'll see that, in fact, when the ventricles depolarize backwards, I should say upwards, superiorly, they're actually moving away from the positive electrode in lead 1 and away from the positive electrode in AVF, and as a result, you end up in this quadrant, which is extreme right axis deviation. This is where you get a negative QRS in both leads 1 and AVF. So that's why VTAC produces this extreme right axis deviation. All right, so I want to add one more thing here, and that is a little bit of a pearl, a take-home message. So the overall QRS axis always moves away from infarction, and it always moves in the direction of hypertrophy. So this is a little something that hopefully simplifies all of the things we have to remember here. So if you think about this, if tissue dies, if it infarcts, it makes sense that the QRS axis will move away from this because, comparatively speaking now, the other side, the non-infarcted side, has more muscle mass than the infarcted side, and we know that it moves in the direction of more muscle mass. This kind of goes along with rule number 2, which is the QRS axis always moves in the direction of hypertrophy because the more muscle mass that exists on one side, the more it draws the overall QRS vector in that direction. So the axis moves away from infarcted tissue, it moves in the direction of hypertrophy. All right, that's it for now. Stay tuned.
All right. So he did a much better job explaining that in very simple terms than I could using these slides.
Right.
Because these slides don't do it justice. There are other blocks that are called fascicles. If you look on that piece of paper, it shows you, you have a, on the left side, you have a posterior fascicle and a anterior fascicle. And that correlates with this sheet, the very right side of this sheet, talks about fascicular blocks. So, he just told you at the end there why some of this is important. So one of the things would be if you have SVT with an aberrant conduction or you have VTAC, how are we going to determine? Well, one way to determine it is to look at the QRS axis. And if it's in the ERAD, right, both down, AVF and lead one down, then chances are it's VTAC and not SVT. So that's one thing to consider. The other thing is that when you start adding these fascicular blocks and hema blocks to it, there's certain medications that can be contraindicated in that. One of them is lidocaine. Lidocaine is contraindicated in what we call a bifascicular block, which means two or more blocks. So like a bundle branch block and a left anterior fascicular block. When you have two blocks together, that's called a bifascicular block. And certain meds are contraindicated in that because it's going to slow the conduction through the system and it's going to cause you more problems. Does that make sense? All right, so what is the mean electrical axis? It's the sum of all electrical impulses, right? And he went through it pretty easy to determine normal axis. Doing the quadrant method is the easiest thing. I'm just going to skip through all these. So this is the handout that I gave you. And it just kind of shows you exactly what he just went through. Normal, left, right, ERAD. This goes through how they calculate it. We're not going to worry about that because our machine does it for us. So if the axis deviates outside the normal range or differs from the patient's pre-existing axis, usually this has clinical implications. So if you have axis deviation, then you need to be looking at it to see if you can figure out why. Okay? If the electrical conduction system is affected, the axis will be directed away from the damaged area, i.e., and then MI, right? So an inferior MI will cause the axis to be directed up and left, causing a left axis deviation. Why? Inferior is what? The bottom. So it's going away from the infarct. Does that make sense? Going away from the infarct. Right axis deviation is caused by events that redirect the electrical axis on the right. So here's possible causes. Who knows what dextrocardia is? Your heart's flipped around in your chest.
I was like,
Ambulance 253 engine 251 medical assignment 1426 Boston Lane Southwest. 1426 Boston Lane Southwest. There's going to be a transport mental subject and interview.
Okay. Yep.
so for axis deviation, is it only referring to electrical activity and nothing to do with the physical location of the heart? Like if the heart was, I guess, moved, like in pregnancy, the heart can get pushed up and turned a little bit, would that show for axis deviation?
Yep.
Okay.
Yep. And if you had your patient like laying on their side and you did it, absolutely. It could change it. It's not going to change it significantly,
Yeah.
but it could. Absolutely. That's why it's so important to get your V leads in the proper anatomical position. Okay? All right, so bundle branches. So a bundle branch block, if you look at your picture, you got your bundle of His, and you got your right and left bundle branches, and then your left bundle branch actually breaks off into those other two branches, the fasciculars, the fascicles, right? So, what's significant about a bundle branch block? Well, where did I say the bundle branches live? In the septum. So, which artery provides blood flow to the septum? The LAD, okay? So let's think that I have a clot in my LAD right where it splits off of the left main. I'm going to affect everything from that point down, right? Include the AV node, including the septum. And if the septum's not getting blood flow, what did it say? It's going to alter the electrical axis through that piece of muscle. So then I'm going to see potentially a bundle branch block. Right? And we know that new onset left bundle branch block is treated just like a STEMI as long as the clinical presentation is there of an acute coronary syndrome. Does that make sense? So, kind of important stuff. How do we know if we have a bundle branch block? Well, if you systematically look at your 12 lead, and we looked at the rate, then we looked at the P wave, the PR interval, the QRS duration. When you get the QRS duration, it has to be over 200 or 120 milliseconds. So it has to be over 120 milliseconds, and it has to be a supraventricular rhythm. So it means it has to have a P wave. Now, determine the right and the left is pretty simple. We only look at V1 if the terminal velocity of V1, which means which direction the QRS is going, that's what we're looking at. Terminal velocity of the QRS in V1. So think about this. You're driving down the road, you're going to take a left turn. Which way does your signal go? Down. You're going to take a right turn? So in V1, if the terminal velocity is down, that's a left bundle branch block. If the terminal velocity is up, that's a right bundle branch block. We don't worry so much about the right bundle branch block as we do the left because of its location. But here's a little piece of trivia for you. If you get a blunt chest trauma and you do a 12 lead and they have a right bundle branch block, that is a very significant finding. Because if you think about the orientation of your heart, what parts up here? The right ventricle. That's the most anterior part of your heart. So it's easier to get it bruised. And if it gets bruised or it gets hurt, then it's going to alter the electrical activity. Does that make sense? So it's kind of important. All right, so that's all of that stuff. All right, hemoblocks. Is that on that piece of paper you got? A block in the electrical conduction of one of the two fascicles of the left bundle branch block causes little or no widening of the QRS complex. Occurs more often in the left anterior fascicle than the other one. So the fascicle is a thin bundle of fiber that conducts electrical impulses to the anterior and lateral walls of the left ventricle. The posterior fascicle forms a broad network of fibers that conducts impulses to the inferior and posterior walls of the left ventricle. So what would be considered a left anterior hemoblock? The left anterior fascicle is blocked. How do we know this? We have a left axis deviation, so that's -30 to -90. We have a QR complex or a large R complex in lead 1 and an RS complex in lead 3. So if you look at your picture there, or the colored picture, you can see what you're going to see on that 12 lead. So the color picture with the 3 or 4 on it is probably the best thing to look at when you're looking at fascicular blocks. A posterior hemoblock, right axis deviation, R wave in lead 1 and a Q in lead 3. Says an extremely rare condition. You don't see it very often. All right, so what did I say a bifascicular block was? 2 blocks, right? So 2 conduction pathways are blocked at the same time. Can occur with concurrent findings of a bundle branch block with a left anterior hemoblock or a left posterior hemoblock. A new onset of bifascicular block with ischemia is not stable. Makes sense, right? The more electrical conductivity that's messed up, the more heart muscle that's involved. And it kind of makes sense. So this one, typically we see rabbit ear appearance, which is called RSR in V1. QRS duration will be 120 milliseconds or longer. So that's what? That's also a bundle branch block. And with a left anterior hemoblock, typical pattern includes an LAD and or a left axis deviation and a RS wave in lead 3. What about that one? Trifascicular block. This is a bifascicular block that also has a first degree block. As a result of disease in the AV node or distal conduction system problems. You don't see these very often either. All right, so what's a hyperacute T wave? A tall T wave, but it's not pointed. It's not pointed. Okay? If we were able to block off a coronary artery and watch the EKG changes from start to finish through an MI, the first change we would see is a hyperacute T wave. It looks like a big tombstone, but the ST segment is still isoelectric. So it looks like a big, huge T wave, but it's not pointed. Okay? When I say a big, huge T wave, as a general rule, if it's more than half the height of your QRS, then it's probably hyperacute. Okay? So what does that tell you? I got chest pain, shortness of breath, nausea, and vomiting, do a 12 lead, no ST elevation, but I got big T's in 2, 3, and F. What?
New onset.
New onset, absolutely. Why do we not see hyperacute T's very often? Because the average person waits 2 hours to call us. So by the time we get there, we see ST segment elevation. Right? So that's a big deal. So the hyperacute T's are localized to the area of ischemia or infarction. ST segment elevation typically is caused by prolonged ischemia or what we know as injury. But what are these? Mimickers, right? Imposters. Things that mess up our ability. So let's talk about this in just a second. So there's your J point, remember? Got to be more than one box above the TP segment. Right? Look at the difference in what this looks like and this looks like. So, persistent ST segment elevation may indicate a ventricular aneurysm. Benign J point elevation, T wave is clearly distinguished as a separate wave. With myocardial disease, the elevated J point bows upward and merges to the T wave. So, ST segment changes can be caused by all these different things, right? Alright, so, can we diagnose an MI in the setting of a left bundle branch block? Okay, get your pens out.
You go cat lab anyway.
Huh?
You go cat lab anyway.
I'm fixing to blow that myth. Oh.
Hello everyone, this is Andrew Walton from MedMastery, and in this edition of Ask Andrew, we're going to look at how to diagnose a myocardial infarction.
There's about 3 or 4 rules that you'll write down.
Here at MedMastery, we take inspiration from our audience members for which topics we should cover. And I'm grateful to all of these members of the audience who have asked us to cover this topic. And the question that we've been asked is, how do you diagnose a myocardial infarction in the presence of pre-existing left bundle branch block on the ECG? Now, it's often said that in the presence of left bundle branch block, it's impossible to interpret ST segment changes on the ECG. But that's not true, and there are criteria available to help us recognise acute myocardial infarction in the setting of a left bundle branch block. And to a large extent, these criteria rely upon what is known as appropriate discordance. This is what we normally see in left bundle branch block. So when somebody has a left bundle branch block pattern on the ECG, if they have a negative QRS complex, then the ST segment tends to appear elevated. Conversely, if they have a positive QRS complex, then the ST segment tends to appear depressed. In other words, there is discordance between the direction of the QRS complex and the direction of the ST segment, normally in left bundle branch block. And we can see that very clearly if we look at the 12-lead ECG. So if we look at leads where the QRS complexes are negative, we can see that the ST segments tend to be elevated in those leads. Conversely, if we look at leads where the QRS complex is positive, then we can see that the ST segment tends to be depressed in those leads. This is appropriate discordance. Now, when we're trying to diagnose an acute myocardial infarction in the setting of pre-existing left bundle branch block, what we're looking for is a deviation from this rule. And this is summarised within the Scarbossa criteria. Now, there are 3 Scarbossa criteria that point towards the diagnosis of myocardial infarction. And the first of these says that if we see ST segment elevation of at least 1 millimetre in at least one lead with a positive QRS complex, then we should start thinking about the likelihood of an acute myocardial infarction. So normally, if we have a positive QRS complex, then normally we see ST segment depression. But if we are looking for evidence of acute myocardial infarction, what we'll be looking for is ST segment elevation in these leads. So in other words, we'll be looking for concordance rather than discordance between the direction of the QRS complex and the direction of the ST segment. Now, the Scarbossa criteria acts as a scoring system, and if we see this appearance of ST segment elevation in the context of a positive QRS complex, then that scores 5 points. The second Scarbossa criterion is similar, and what we're looking for here is evidence of ST segment depression in the presence of negative QRS complexes. And the negative complexes that we're looking at are those in leads V1, V2, and V3. Now, normally in those leads, we will see that the ST segments are elevated because appropriate discordance says that if you have a negative QRS complex, you should have ST segment elevation. However, if the patient was having an acute myocardial infarction what we'd be looking for is evidence of ST segment compression in these leads. And if we saw that, that would be concrete, and so that would be abnormal. And if we see this, then we score 3 points. The third and final Scarbossa criterion is a little different. Rather than looking for concordance, what we're looking for is extreme discordance. What we're looking at are negative QRS complexes, and we're looking at the amount of ST segment elevation in those leads. Now, normally we'd expect to see some ST segment elevation following a negative QRS complex. But what we're looking for the Scarbossa criteria is evidence of very exaggerated ST segment elevation, and this is when it measures 5 millimeters or more in height. And if we see that, then we score 2 points. So having looked for evidence of these 3 different Scarbossa criteria, we add up the total number of points scored. And if the patient has a score of at least 3 points, this indicates a 90% specificity but a poor sensitivity for a diagnosis of myocardial infarction. In other words, the Scarbossa criteria are good for ruling in a myocardial infarction because of their high specificity, but are not so good at ruling out myocardial infarction. So if we apply the Scarbossa criteria to this ECG, the patient certainly scores 2 points because they've got very marked ST segment elevation in leads with negative QRS complexes. There's at least 5 millimeters of ST segment elevation in these leads. But they do not have ST segment depression in the anterior leads, nor do they have ST segment elevation in leads with positive QRS complexes. So their total Scarbossa score is just 2, and therefore they do not meet the criteria for the diagnosis of acute myocardial infarction. It's worth remembering that the Scarbossa criteria can also be applied in right ventricular pacing. You might be aware that when a patient has right ventricular pacing, they have a left bundle branch block morphology on the ECG. And we can apply the Scarbossa criteria in this setting to diagnose an acute myocardial infarction. However, although the Scarbossa criteria do still work in the setting of right ventricular pacing, they are less specific in this context. In other words, they're not quite so effective for making the diagnosis of acute myocardial infarction. So in conclusion, I hope I've been able to answer your questions about how we diagnose acute myocardial infarction in the setting of left bundle branch block. If you'd like a reminder of the Scarbossa criteria, then take a look at the handout that accompanies this video.
All right. So I've printed off the Scarbossa criteria for you. So there's that myth busted, myth buster, right there. All right. What's hypertrophy? Huh? Enlargement of what? Specifically, it's thickening. Thickening of the wall, right? So think this through. The thicker the wall, the longer it takes for electricity to go across it, right? So what's it going to look like on the EKG? Big long sucker, right? But is it wide or narrow?
Narrow.
Narrow, correct. What causes, like specifically left ventricular hypertrophy?
Heart failure?
That's not what causes it.
Overworking, so
Dude.
fighting pressure.
Yeah, fighting high blood pressure. That's typically why you get left ventricular hypertrophy. Now that could lead to heart failure because once it gets so thick, it can't get thicker, it's going to get floppy. When it gets floppy, then it's inefficient. It doesn't pump efficiently once that happens. Does that make sense?
You
You see hypertrophy with some athletes too?
You shouldn't. I mean, I guess you could, but you shouldn't.
Okay.
Because it's pretty abnormal, so. All right, left atrial enlargement. Again, that's because typically we got something backed up, right? We got a large left atrium, and that's because it's having to pump hard against the left ventricle, because the left ventricle's got high pressure in it. Left ventricle's got high pressure in it because it's pumping against high blood pressure, right? So we get left atrial enlargement. And what does it say? It results in a prolonged electrical conduction time through the left atrium, gives rise to the end or the trailing side of the P wave. So that goes back to your P wave thing, right? Makes your P wave look different than round. Okay? What did we call this? P mitral, because it's a mitral valve problem. So it looks like an M, right? The P wave looks like an M. So it says it's notched or double humped. P mitral, P wave lasts longer than 120 milliseconds in the limb leads 1 and 2 and has a notched appearance. So typically it's the notched appearance that's the problem. Right atrial enlargement, COPD is the #1 cause. So it's usually some kind of pulmonary issue that's causing backing up into the right side, and that's causing the right atrial enlargement. So then we get these big, tall, peaked T waves that are higher than 2.5 millimeters, right? And they're typically pointed. You get a biphasic P wave in V1, and a biphasic P wave that's seen in also AICDs are related to atrial enlargement. What's an AICD? Yeah, automated implanted cardioverter defibrillator. Biatrial enlargement, both atria enlarged at the same time, so we get the double whammy P wave looking things. We get the biphasic P waves in some of the leads, and we get the tall pointed P waves in the other leads. All right, so here's LVH, diagnostic criteria. Any precordial lead over 45 millimeters. Okay, so each block up and down is a millimeter, right? So if you get an obvious one that's 45 millimeters, then you're done. If not, we have to look at something else. So we look at lead 1 or it's V5 or 6, whichever one is taller versus negatively deflected. We add those together, and if it's over 35, then you have LVH. So, not a big deal. All right, strain patterns. This is something you see with subendocardial ischemia. You may see changes to the ST segment and the T wave. Strain pattern is greatest in leads with the tallest and deepest QRS patterns. So it can also occur in LVH and RVH. So right precordial leads, so V1 through V3, strain pattern is seen as ST elevation with a concave appearance and an upward slope. T wave is upright and asymmetrical in these leads. So we're not going to get too much into strain patterns because it doesn't really make a lot of difference to us. WPW. This is a pre-excitation syndrome. Occurs when there's an accessory pathway for current that bypasses the AV node to enter or re-enter the ventricles. This pathway is known as the bundle of Kent. It does not have the same ability to slow conduction impulses through the AV node. So typically, what dysrhythmia do we see with WPW? And who's prone to WPW? We typically see PSVTs or SVTs. right? And it's typically in young females. So you get this 16, 17-year-old girl that has multiple syncopal episodes, and they put her on a heart monitor, a Holter monitor for 24, 48 hours, and they're looking for that. Okay? So, what is the characteristic that we see on the EKG for WPW? A delta wave. And what does a delta wave look like? So it's a slurred upstroke.
Where a J would normally be, right?
What's that?
Where a J would normally be.
Yeah, so it would look like this, and our normal one looks like that, right? Straight up, and our T wave. With a delta wave, you get this slurring here. That's what a
Delta
delta.
last week, she happened to be a nurse practitioner, her husband's a physician, all of a sudden I pulled up, she's like, here's the deal, here's what I got, here's what's going on. Take her to the hospital. Well, what do I do? But yeah, she sat there and gave us a whole little lecture on.
WPW?
Yeah.
So it was her that had it?
She's, what was she, like 20-some, 30?
Yeah.
She gave you a lecture while you were out the back end.
Well, funny enough, I've transported her before.
PowerPoint.
She was one of the nurses that delivered Megan, so I've kind of quasi-known her for a little while. She had ultramotor on.
So here's the thing, one of the things about this, what causes this kit bundle of kit, you got your normal electrical pathway that goes through the AV, bundle of His, right and left bundle branches. Well, this is an extra wire, goes through the AV, gets to the bundle of His, and there's an extra wire that goes back up on top of the AV. So it does this. So that's called a re-entry arrhythmia, and that's why it's so fast. Because it's not slowing down through the AV, it's bypassing the AV. And so that's why it's going super fast. Does that make sense? What's the one thing we really want to know about this? Why we want to know about this? What drug would we normally give to SVT? Adenosine. Can you give adenosine to WPW? You better not. Better use something else. Beta blocker, diltiazem, something. But don't be using adenosine.
Will you be able to see that pretty clearly even in SVT? So you just hope that they can pass that information on to you
Well,
at one time?
yeah, but usually you can see it pretty good, and your printout on the top will usually identify it for you too.
Okay.
Either say delta waves or suspect WPW or something. So that's your clue to look a little closer to it, you know? All right, what's pericarditis? Inflammation of the pericardial sac. So here's the characteristics of it, okay? It's typically a young, healthy person who's had a viral infection or been around somebody like their kids who had a viral infection, like a cold, and it migrates to their heart, okay? They will have chest pain, but here's the thing. When they lean forward, the pain gets better. When they lay back, it gets worse. Think about it. Anything that's going to put pressure on that sac that's irritated is going to cause it to hurt, right? Taking a deep breath puts extra pressure on it. Going to make it hurt. Okay? And then your characteristic EKG changes are what? You know?
Elevation everywhere.
Everywhere. A little bit of elevation every single lead. All right, we talked about long QT syndrome. It can be a congenital problem. Can deteriorate rapidly into life-threatening conditions. Measurement, again, depends on the heart rate. So the slower it is, the longer it is. That's why bradycardia is like from, beta blocker overdoses and stuff like that. Prolongs your QT, sets them up for torsades. All right, wide complex tachycardia refers to any rhythm that's over 100 and wider than 120 milliseconds. So, under ACLS protocols, if we're not sure if it's SVT with an aberrancy or VTAC, what can we give them? Adenosine, right? We use adenosine as a diagnostic tool if we're not sure. Here's what I will tell you from clinical experience. If they're stable, like hemodynamically stable, it's probably SVT with an aberrancy. If they're not stable, it's probably VTAC as a general rule. But one of the ways we know how to help us identify that.
Access.
Right, and which axis would indicate VTAC? ERAD, extreme right axis deviation, no man's land. Right? So negative 180 to negative 270. In 1 and F. Both will be down. Right? So about that axis deviation stuff, this goes along with your little deal, but just think about this. This is lead 1, this is AVF. Normal? Correct? Which one's positive? So that's a left axis deviation. It's not that hard. Right? And we use those numbers. That's the easiest way to do it. Just use your number. Now, on that 12 lead, does it show the P wave axis on those 12 leads I gave you? Yes. And what's the first number?
79.
Okay, and what did I say it was supposed to be? Zero to 75. So, something you never knew before. All right. Ventricular and wide complex tachycardia typically is over 140 milliseconds. Look for concordance across the precordium. So what's that mean? Concordance. Everything's going the same direction. The T waves and the QRS are all going the same direction. So if they're sick, they get electricity, right? If they're not sick, we give them drugs. Hyper K, high potassium level. What's normal potassium? 3.5 to 5. Okay? We don't worry about it too much until it gets above 5.5-ish. When you get to 6.8, you start seeing those big monster T waves. The heart is very, very sensitive to potassium and it does not like it. Doesn't like high or low, but specifically doesn't like high potassium. So, when we start seeing these big, tall, peaked, like TPs, and that's the way you remember it is, if you sit on that T wave, it hurts your butt, then that's probably hyper K. Okay? You can also see P wave abnormalities, either missing or decreased amplitude P waves. Cardiac arrhythmias, typically bradycardias. Hypokalemia, low potassium, so below 3.5. Typically, I don't know, what do they consider critical? Below 3.2?
I think it's
2.5? You see widespread ST depression, and ST depression's really not a good term for it as much as it's flat. The ST segment gets flat more than it gets depressed. You get a slightly decreased in the size of your T waves, and you might get a U wave, which is a small little wave after the T wave. It kind of looks like a U. hyperkalemia or calcemia, so high calcium. I think the normal for that is above 8. If it's above 8, then that's abnormal. So I think it's 5 to 8 is normal calcium. No? 10 is high. Shortening of the ST segment, which in turn shortens the QT interval. I think that by definition, this is below 350 milliseconds. Is too short. QRS might get wider, and T waves may invert or flat. Hypocalcemia, ST segment gets very long, and that produces a long corrected QT interval. What's DIG toxicity do to you? Everything. DIG is an old drug. It was primarily used for AFib, for rate control. It's not very widely used anymore. The problem with it is that the therapeutic range and the toxic range are super tight. So if you get DIG toxic, it can cause every dysrhythmia known to man. PVCs, Renza-VTAC, blocks, Brady's, you name it, it does it. As well as, if they get really high, they will start seeing yellow halos around everything. That's kind of the characteristic thing. What's the treatment for DIG toxicity in the hospital? Nurses. It's called Digibine. It's a specific drug for digitalis that binds it and allows you to poop it out, basically. So, just like I said, you can see every single weird rhythm known to man with DIG toxicity. So, we talked about conditions that mimic MIs, pericarditis, left bundle, left ventricular hypertrophy, ventricular stuff, and then BER, benign early repolarization. We know the risk factors for CAD, right? Hypertension, cigarette smoking, diabetes, cops, firemen, paramedics, ER nurses, lack of exercise, obesity, bad genes, being a male. Arteriosclerosis is what? Hardening of the arteries, right? You can get a couple of significant things with this. One's phlebitis. Phlebitis is inflammation of the veins, and the problem with that is that it can cause you to create a clot, and then when you get a clot, it can dislodge, and then we can have a PE or a stroke. What's the difference between a embolism and a thrombus?
Thrombus is where it originates.
Correct. So an embolism starts somewhere else and travels. A thrombus is formed at the place. Yep. So, oral contraceptive use, smoking, recent surgery, all of these things increase your risk for what? Clot formation, exactly. All right. Signs of peripheral vascular occlusion. What we're talking about here is typically we're talking about either deep vein thrombosis or we're talking about arterial occlusion, right? So pain, and when I say pain, it's out of characteristic for what you're seeing. So very, very significant pain that you can't get a good hold on with your narcs. Redness, swelling, hot to touch, and tenderness. You see all of these things typically in people's calves. This is where you get your deep vein thrombosis in the calves. That's a poster child for that. What would lead me to believe I have an arterial occlusion? What's that?
Diminished pulses?
No pulses. Yep. So pain, pallor, so very, very, very bad pain, pale, paresthesia, so numbness and tingling, and pulselessness. All right, we know that ACS is what? It's an umbrella. Under that umbrella, you have unstable angina, non-ST elevation MI, and a ST elevation MI. Anybody with potential cardiac events should have 12 lead. And when should it be done?
Then first 10 minutes.
Should be done as soon as possible, right? That's why I harp on you guys to take the freaking monitor in. Do it in the living room, do it in the kitchen, do it in the bedroom. Don't wait till you get in the back of the ambulance. Okay? That's a 15 to 20 minute delay in getting a 12 lead. Not good. So, what are we looking for? ST elevation or no elevation, right? Does no elevation rule out an MI? No. Back up. The more leads that show ST elevation, the higher the mortality rate. Does that make sense? More leads, more heart muscle. More heart muscle, more problems. Kind of common sense, right? That's why they call it the widowmaker. I have septal, anterior, and lateral or inferior problems. That's pretty much the whole left ventricle. All right, so transport priorities with ACS. Prevent further damage to the heart. Translation, nitroglycerin. Remember, nitroglycerin is not a pain medicine. It's an anti-ischemic medicine. What's that mean? How am I going to know if they're having ischemia? Because I did a 12 lead. Right? 50% of people having MIs don't have chest pain. They have an anginal equivalent. Shortness of breath, weakness, pulmonary edema, palpitations, nausea, vomiting, something else. I do a 12 lead. I get ST segment elevation. They don't have chest pain. Do I give them nitro? You better give them nitro. It's not a pain medicine. It's an anti-ischemic medicine. I have graphic proof in your face that they're having ischemia. They get nitro. Plenty of people in the ICUs and the ERs on nitro drips without what?
Chest pain. No, chest pain.
Exactly. That's the point. Right? How are we going to reduce afterload? Do that with nitro also. Make the container bigger, lowers the pressure. Right? How do we prevent the clot from getting any bigger? Aspirin. How do we reduce myocardial oxygen demand? Maybe oxygen, but what else? Maybe we give them beta blockers if they're tachycardic. Slow their heart rate down. Maximize oxygen delivery. So current HA standards are, if their SATs are over 94%, they're not having shortness of breath, you don't have to give them oxygen. Reduce or eliminate the pain and anxiety. 2018, there is no reason for somebody to hurt. We have lots and lots and lots of drugs for that. And then consider TPA. We don't do this that often. What's the criteria for this now? If it's over 60 minutes to get them to the cath lab. So we're still not seeing it done. Even when the cardiologists tell the rural hospitals, hang TPA, they're still not doing it. It's like they're afraid of it or something. I don't know. It's been around since the 80s. It's not like it's that big a deal. What's angina? Chest pain caused by what? Oxygen demand problems, right? Typically it's brought on by exertion and it's relieved by rest and nitro. What's the difference between stable angina and unstable angina? So a change in the pattern. So typically I go mow the yard, 20 minutes in, I get 5 out of 10 chest pain. I sit down, I pop a nitro, it goes away. Today, I walk out to get the mail, walk back. Now I got 5 out of 10. I've taken 3 nitros and I'm sweating. Unstable engine. So a change in the characteristic or a change in the pattern associated with the ischemia. All right, MI. Once the muscle's deprived of enough blood and oxygen, it starts to die. Location of the MI depends on which coronary artery is blocked and where the blockage occurs. Most MIs involve the left ventricle. Inferior wall MIs are a result of RCA. We know that. When the ischemic process affects only the inner layer of the muscle, this is called a subendocardial infarct. When the infarct extends through the entire wall, it's called transmural. The difference between these two are whether somebody has pathological Q waves or not. So what's a pathological Q wave? But what is it? Tell me what would tell you it's a pathological Q wave. The Q wave is over 1 box wide, so 40 milliseconds wide, then that's considered pathological. Okay. That's my left ventricle. Impulses start in the endocardium and work their way out to the electrode, right? Okay. The muscle causes the electricity to slow down as it's going through there, right? That's what gives you the height of your QRS. So think this through. Let's say that I have a big MI right here, and it's through the muscle, it's transmural, right? And this is infarcted. This is dead tissue. Is it going to be easier for electricity to get through it or harder for electricity to get through it? It's actually easier because it's dead. It's not perfused, so it's electrically silent. So what you see is you get this impulse that starts here and goes this way, and then a little bit of electricity leaks out here, and it causes that. That's a pathological Q wave. So let me ask you this. If only that much of my muscle was dead, would I have a pathological Q wave? No, because this is still good muscle right here. So it's going to go out, but it can't go the other way. So the translation, why I'm telling you this is, pathological Q waves tell you there's a significant piece of muscle that's dead, and it's electrically silent. And what you're getting is feedback from the other side when it fires. Okay? How many of you have seen your 12 lead spit out and say, MI suspected, age undetermined? That's what it's picking up. Pathological Q waves in a pattern. 2, 3 and F, B1 and 2, B3 and 4, 1 and L, whatever the pattern is. Right? Just like an MI. It says age undetermined because you don't know is it 2 hours old or 20 years old. Once you have pathological Q waves, you always have them for your whole life. There's no way to tell without other EKGs to compare it to. That makes sense to everybody? So who are our MI patients that are at risk for sudden death? Prior cardiac arrest, prior MIs, those who are in heart failure with ejection fractions of less than 40%. So what did I say normal was? 70, right? Family history of cardiac arrest, prolonged QT interval. right, we already went through blood flow a lot, so we're skipping through that. Wrong.
Which is what flow said?
Yeah, we went through
Can
blood
we go
flow.
back through that again? Don't be that guy.
All right. So, anterior infarct, where am I gonna see elevation? V3 and V4. Which arteries involved?
Goes back out.
V3 and V4.
LA.
LAD, left anterior descending. Anterior septal, which artery? LAD. Where am I going to see an anterior septal? Septals V1 and 2, anteriors V3 and 4. So it's going to be either 1, 2, 3, and 4, or maybe 2 and 3. Right? Because they're numerically sequential V leads. Acute anterior lateral MI with lateral wall extension. We will see them in 1 and AVL also. Lateral MI, 1 AVL, V5, and V6. Then we're going to see reciprocals in 2, 3, and F. So what are reciprocals? Mirror image opposite, right? Cool thing is that if you have them, it's more compelling evidence that you're right, but you don't always have them. And you don't always have reciprocal changes. Inferior, 2, 3, and F. We talked about the 90%, 10% people. Reciprocal is going to be in 1 in AVL. And then what do we always do if we have an inferior injury pattern? At least V4R, right? The catch is 92%. Inferior lateral, 2, 3, and F. And then some of your V leads, 1 AVL, V5, or V6. We'll see reciprocals in the anterior leads. An apical MI is an extension of an inferior lateral. So what's the apex? It's the point. So we're wrapping around that whole thing. Acute apical MI occurs in patients who are right dominant. Right dominant. All right, RVI. Again, 33% of inferiors have RVI. So anybody that's got an inferior injury pattern, you do right-sided before you give them any nitrate. What's the significance of that? If you have RVI? Preload dependent. Preload dependent. All right. Cardiomyopathy. Myocardium becomes thin, flabby, dilated, or enlarged. So typically you see this after a big anterior MI. Basically the muscle's floppy and it's pumping ineffectively. These are your patients who are in congestive heart failure. Can also be in heart failure from valve issues, direct damage to the muscle from an infarct, conduction abnormalities such as what? So significant bradycardias, right? Nerve fibers develop with an increased density that can lead to VTAC and VFib. In these cases, infarcts involving the septum, synchronization between the ventricles is lost. So, remember, left lungs. The left heart fails, the lungs fill up. That's congestive heart failure. Your lungs are congested because your left heart is failing. That's CHF. There is some confusion about the use of Lasix. Okay, a lot of people don't use Lasix anymore. Here's what I'll tell you. A large majority of people that are in left-sided heart failure and their pulmonary edema, it's not because they're fluid overloaded. It's because the fluid's in the wrong place. So what do we do about it? CPAP. Nitro and CPAP. We unload the left ventricle and we push it back into the capillaries. A lot of people still want to just jump on Lasix. And the reality is, a lot of places, you don't need Lasix. If they got pedal edema, sacral edema, jugular vein distension, okay, maybe give them some Lasix. But if all you're seeing is pulmonary edema, probably not going to give them Lasix. So what kind of stuff do we see? History of 1 or 2 weeks of paroxysmal nocturnal dyspnea, PND. They can't breathe laying flat, so what do they sleep on? Lots of pillows, right? Or a chair, exactly. So, our goals, decrease pulmonary congestion. How are we going to do that? CPAP. Reduce afterload. How are we going to do that? Nitroglycerin. Normalize their myocardial oxygen, so give them some O's. Decrease myocardial oxygen demands, so make them rest, or if their heart rate is too fast, we give them beta blockers to slow it down. Right-sided heart failure, typically because of left-sided heart failure. Seldom a life threat by itself, unless it's caused by right ventricular infarct, and then it could be a problem. Treatment is not much. We talked about pulmonary edema. What's the difference between CPAP and BiPAP?
CPAP is continuous, BiPAP is
Yeah. So CPAP is continuous positive airway pressure at a certain much of pressure that you dial in. BiPAP is CPAP, and then when they take a breath in, it gives them higher pressure to help force it out. So some ventilators, transport ventilators, will do BiPAP, but mostly we do CPAP in the field. So our goal in these patients is not to intubate them. That's why we invented CPAP. That's why it's a BLS skill. All right.
Chief,
Yep.
I took a lady in, I don't remember who working with me though, I don't remember what she was though. Truck driver lady, she was just, they were semi-road. She had a nasal cannula, she called it a high flow nasal cannula, it had like a circular piece here. I can't remember what she was running at like 20 or something like that.
Yeah, it's doing the same thing.
Like the bypass.
Yep. So if you look right there, high flow nasal cannula.
I've never seen it before.
Yeah.
That's the same thing in theory with the, I didn't hear all what you said with those old folks having home with the nasal cannula.
This lady had, it was a disposable nasal cannula, it had like a circle piece here. I don't remember who was my partner that day. I took her to the hospital, got her to the truck stop, and it was running at like 20 or something like that. She was worried about, it was paramedics, worried about running out of oxygen basically. And it was just like, the whole dang time. It was a nasal cannula.
It's for people who can't take the whole mask.
She was on it like all the time.
I think they're using them in hospitals on BiPAP patients when they have to eat their meals too. We'll switch them over to the cannula so they can actually put food in their mouth.
Yeah, and a lot of your neonates and infants that are on CPAP in the NICU, they're on nasal CPAP. So why? Because they're obligate nose breathers, right? So. All right. So what's this talking about? Cardiac electrophysiology. They do what they call mapping studies. So if you have a problem with a dysrhythmia, especially like a ventricular tachyarrhythmia, they will map you. It's kind of like doing an EEG on your head, except they do it on your heart. They find exactly where the irritable focus is, and then they send in a catheter and they burn it. It's called an ablation. So they burn that irritable focus so it can't do that anymore. Does that make sense? Implanted pacemakers. So this is people who have diseased hearts or temporarily have to have a pacemaker because of an MI. And I gave you 2 sheets that go along with pacemakers. This one tells you what the abbreviations stand for. And this one gives you examples of what they are. So basically, it tells you where it senses, if it's atrial or ventricular. Now, here's the thing. People who have pacemakers have a card, they carry a card in their pocket that has these things on it. So if you didn't know, you just knew they had a pacemaker, they should be able to give you a card, and you should be able to look at that card, compare it to your chart, and figure out exactly what kind of pacemaker it is, what it does. Where pacemakers usually implanted? Left upper chest. Sometimes they can be in the left rib cage, and occasionally there's some reason that they put them in the right. Problem with putting them up here is our defibrillation pads. Problem with putting them here is our defibrillation pad. As long as you're 2 inches away from the generator, you're okay. Usually it's up here, and that's the reason they put them up there, is because then it doesn't interfere. Okay? All right. AICDs. These are cardioverter defibrillators, and these are put into people who have sudden death syndrome, so like VTACs, torsades, those kind of things. The long QT interval that's led to torsades or whatever, they put these in. It says that studies have shown that they're up to 99% effective. So if we get a patient and they say their defibrillator's gone off, we put them on our monitor and do all our stuff, and they run into VTAC, what are we gonna do? Let their thing take care of it, right? Unless it's not. Will it hurt you to be holding on to them when it goes off? Most likely not. Okay? I had one guy once that his AICD was at 80 milliamps when it went off, and it would scare you. I mean, like it got you pretty good. And then I was starting an IV when it did it the first time. And I was like, okay, tell me when you feel that. Because typically you're in that rhythm for 15 to 20 or 30 seconds before it shocks you, right? So he would tell me, and I'd get away, and we'd be doing something. It went off 8 times for my ambulance.
Is that you and I, the guy who's like, it's gonna go off again?
Let
I
it go.
feel it.
It's doing what it's
Yeah.
supposed to do.
Yeah, it hurt.
Every time it'd go off, he's like, here it comes, it's gonna go again.
Yeah, so they know.
So can you give them pain meds right now just to kind of ease it a little bit, or?
Well, it doesn't hurt them.
Really?
No. And it's kind of like being tased. Once it's over,
Yeah,
it's over.
this guy
This guy was
You said,
screaming.
Yeah.
He was hurting it?
Oh, yeah.
Yeah.
you said it was at 80 milliamps?
Yeah.
I mean, that's only double what you're pacing.
Yeah, but this is directly attached to your heart muscle.
Right. But I'm just saying, like that makes me nervous now to touch anybody at pacing. Like, if
Well-
you could feel it, like. Huh,
Yeah. But I
interesting.
mean, we used to pace asystole and we did CPR in between your pads. So,
That is,
Yeah.
80 milliamps isn't very high.
yeah, I mean, most of the time you're talking less than 1 milliamp is what they're set at. So like 80 milliamps was a ton of electricity. So, all right. Who knows what this is? It's a life vest. This is typically what we're seeing now. People are put in for 3 months before they get their AICD. Doug and I was at Wendy's one day, and this call come out at 65 in Hubble, and we got there in like 30 seconds. It was a CPR. Little skinny guy, homeless dude riding his bicycle, picking up cans, and we worked him. We got him back. We found out later he was supposed to be wearing a life vest, but he didn't. Rode all the way from the homeless shelter by Station 1 downtown out here to pick up cans.
How many times have we shocked him, like 11?
Oh, yeah, like a ton. And as I was trying to intubate him, he's in V-fib, I'm trying to intubate him, he's biting my laryngoscope, like he's going.
Oh,
It was weird,
300
wasn't it?
amiodarone and 100 Alido, still couldn't convert him after the 11 shocks. That was bizarre shit.
And the guy probably didn't weigh 100 pounds. So, yeah, it was crazy. So, wearable defibrillators have 98% effective in terminating lethal arrhythmias. So, first implanted pacemaker was in 1960. It was asynchronous and paced without regard to the heart's intrinsic rate. Single chamber demand pacers appeared in the late 60s, and in 79 the first dual chamber pacemaker was introduced. Single chamber rate responsive pacemaker, what does that mean? It's only going to kick in when it needs to,
On demand.
right? Yep. Today, dual chamber pacemakers use rate responsive pacing to mimic the heart's rate response and meet the metabolic demands of the body. So, who gets pacemakers? People with sick hearts, right? People with sick hearts. Reflex syncope, symptomatic sinus brady, third degree blocks, second degree type 2 blocks, sick sinus syndrome. And then we can do overdrive or anti-tachycardic pacing. Has anybody ever seen an overdrive pacer? So this is somebody that won't slow down no matter what you do to them. Cardiovertum, whatever, they won't slow down. So you turn your pacer up, you capture it, and then you try to slow their rate down with it.
does that work?
Yeah.
You just turn your milliamps way up when you do that, or?
Yep.
Turn up till it captures it, and then start backing it back off.
So, transcutaneous pacers, that's what we use, right? Multiple pad, or multifunction pads put on the patient's chest. It's a temporary thing till we get a transvenous in. Here's what I'll tell you about it. If I'm gonna pace somebody, and I'm specifically going to pace them, and I know I'm going to pace them, I do A and P pads instead of this. I think it works better. I have no scientific proof of that, just my experience. It's more likely to capture when you sandwich the heart versus just going across the front of the heart. So, yeah. So we talked about these already. The transthoracic and epicardial pacemakers, they just hook wires to whatever part of the heart they want to pace, and then they put that generator up under the skin. Batteries are good for 10 years usually, and then they have to replace them. Some places carry magnets to turn off the pacemaker in case it's haywire or in case, they're in cardiac arrest or something.
We had one of those at the Preston. Like we had like the whole machine in there, and we brought them in. We could run the whole diagnostic, sit it on it, and we could turn it off, turn it back on, run the whole diagnostic. It was only certain brands that we could do, but it was kind of a neat thing that sat there and collected dust.
Well, like the phones now too. Like my grandpa had one that he would just call in to the cardiologist, and they were able to get it through the phone.
Wow.
Yeah.
That is really cool. All right, what's a transvenous pacer? They flow pacer wires through like your subclavian, get it into the right part of the heart, just keep it stimulated that way until they can go in and put the permanent pacemaker in. So that's what they usually do in the ER, is float a pacer under fluoroscopy or sono or something. So that's what it looks like. Just turn up your milliamps, turn up your rate. So 95% of pacing leads are endocardial leads, threaded through the veins in the right atrium or right ventricle. Maybe unipolar or bipolar. Unipolar has one conducting wire and a single electrode. Bipolar has more than one. So that's what it looks like. So they float it into the subclavian vein and stick it into the right atrium or right ventricle. Once they become contacted with the heart tissue, it's negatively charged when the electrical current is flowing. And then it receives its energy after depolarization. Single chamber, dual chamber, we talked about those. The MBG codes, that's what I gave you. First letter identifies the chamber that the pacing is occurring. Second letter identifies the chamber where the pacing is sensed. Third letter is the pacemaker, indicates how the pacemaker responds. And the fourth letter identifies the pacemaker's programmability and rate modulation. Fifth letter represents anti-tachyarrhythmia functions. So, basically what I gave you there. Troubleshooting pacemakers. Why they fail. Typically it's battery failure. Usually that's a 10-year battery. Sometimes the leads come off, especially within like 4 to 6 weeks after they put them on. Sometimes the leads come off. Coiling or damage to the lead generator interface. So you move or something the wrong way and it becomes unplugged. Dislodgement of the lead. Pacemaker programming problem. Pacemaker pocket stimulation. So something's causing it to do what it's not supposed to do. What's this? Diaphragmatic stimulation. It's making your diaphragm move instead of your heart muscle. Signs of pacemaker failure. Anything that causes hypotension, right? If they're bradycardic, if they're in heart blocks, any of that kind of stuff, they shouldn't be, because that's why they have a pacemaker, right? All right, an ICD can be temporarily disabled by a magnet to prevent further discharges. Put it directly over the pulse generator. It says before using a magnet, multifunction pads must be in place and hooked up to the monitor in case we need to continuously pace them. In cardiac arrest, external defibrillation can be delivered, but the paddles or pads should not be placed directly over the generator. We're just going to go through these. All right. Be back at 1.